Assalamu alaikum. I am privileged to invite Professor Khadija Irfan. She is a professor of endocrinology, Institute of Endocrinology and Metabolic Disease in Service Hospital. She is a project lead in the Punjab Institute of Diabetes and Endocrinology, and also a country lead and a member steering committee of NIHR Global Health Research Units in Diabetes. She will talk on the topic of her presentation is of Ozempic babies and other things, impact of maternal endocrine disorders and their neonatal effect.
Assalamu alaikum. Thank you for your kind introduction. All right. I feel a bit out of place in this gathering of neonatologists as a person who's going to be talking about mothers. And perhaps that is something we really need to see, that where does the adult endocrinologist fit in this scenario where the endocrine diseases of the newborns are being talked about. And perhaps I will make this a bit clear. So I do not have any financial disclosures, and some generative AI was used. My talk is going to be in two main parts. In the first part, it's going to be a little bit of mechanistic understanding and a historical journey. And in the second part, I would then focus on how the maternal endocrinopathies, which we see in adults, can be expected to reflect on their newborn babies. Okay. So let's first look about the maternal fetal continuum. John Donne said that no man is an island entire of itself. It's a part of the whole, part of the continent. I'm paraphrasing a bit. I think that is a bit more relevant if you talk about the fetus. No fetus is an island. It's a part of the whole thing. And if you entirely look at the fetus or at the neonate, you're missing the one half of the whole. So it is a continuum. The audience of neonatologists, I'm sure this is a very common sight you see almost every day in your neonatal ICUs. So this was noted as far back in the 1950s, where in this very important and, shall I say, landmark paper, a Danish epidemiologist, Pedersen, mentioned that at birth, infants of diabetic women are held to be bigger, fatter, and more edematous than those born of normal mothers. And this was his observation back in 1952, and he tested this. And he tested this by looking at the weights of infants born to mothers with diabetes, as well as infants who were born to control mothers. And they found that on an average, nearly half a kilo heavier and nearly 1.5 centimeter longer babies were born to mothers of diabetic infants. The conclusion he drew was that maternal blood sugar is the primary driver of this overgrowth. And his concept was maternal hyperglycemia. He proposed this mechanism. He proposed maternal hyperglycemia leads to fetal hyperglycemia, which leads to fetal hyperinsulinism and then macrosomia. And this came to be known as the Pedersen hypothesis. But although this was described and it became very much a canon of neonatology, it was also noticed that even some diabetic mothers who achieved almost perfect glycemic control were still giving birth to very large babies. And the conclusion which he drew was that perhaps there were some other substances which are responsible for this macrosomia. There were other substances which are crossing the placental gatekeeper. And this signaled a shift from a single nutrient, glucose-only mechanism to an understanding of fetal growth, which is influenced not just by glucose, but by other things. In 1980, this very important lecture was delivered by Norbert Frenkel, and he suggested, he gave an understanding of the pathophysiology of a diabetic pregnancy. And he says that in diabetic pregnancy, first of all, there are three main cardinal features. First of all, there is a heightened metabolic shuttling between the fed and the fasting states. Secondly, he likened pregnancy as a tissue culture, and he said that the medium is derived from the maternal fluids. And lastly, if these maternal fluids and these abnormal fuel mixtures reach the baby, the influence will not just be at the neonate, but will last beyond that neonatal period. So he likened the topography of the maternal glycemia in the non-gravid as well as in the gravid state. The difference in these he likened as that, whereas you can say that in a non-gravid woman, the glycemic excursion which occurred between the fed and fasting state can be likened to the gentle hills of Berkshire. Whereas in late pregnancy, where the gravid state fully comes into its own, the glycemic excursions are like the Alps, the craggy hills of the Alps. And this is because pregnancy itself is a diabetogenic state. In normal pregnancy, maternal insulin resistance increases by 60%. And this is done as a protective mechanism to ensure that the maternal glucose levels stay high enough so that there is always a gradient down which the facilitated diffusion into the fetus can occur. So during the feeding phase, the increased elevation, the increased amplitude of the glycemic spike, as well as the increased duration of the glycemic spike ensures a consistent high gradient down which the fuel will reach the fetus. And in the fasting state, the mother's metabolism shifts to alternative metabolites such as the fat metabolism, so that the fetal glycemic access stays uncompromised. Maternal insulin resistance, therefore, is made to protect fetal nutrient supply. It is a physiological mechanism. It is needed, and it is done with a good purpose. However, if there's an excess of nutrients, what happens? And especially if that excess of nutrients occurs at this phase, which is, you can say, that the critical period at which the organogenesis is occurring, then these very same fuels which were needed to drive the fetal growth in a normal fetus becomes teratogenic. It develops not only macrosomia, but it develops and leads to other abnormalities such as neural tube defects, etc. With this understanding came up the understanding that it wasn't just the glucose. And this was again proposed by Dr. Frankel. And he says that in addition to glucose, there are specific amino acids, especially the branched amino acids, which are also important for fetal insulin release, and they contribute to macrosomia. So it's not just glucose. And this may perhaps explain why mothers who are normoglycemic through the pregnancy still develop macrosomic babies. And this has been called the concept of fuel-mediated teratogenesis. From the Peterson hypothesis of fuel-mediated teratogenesis, there was another shift to the Barker hypothesis, which then suggests the fetal programming. And the concept here is that not only the neonate who is born to these mothers who are exposed to influences during their intrauterine stay, not only that, the changes occur not only in the neonatal period, but this stays and manifests as adult disease. This is called the developmental origin of adult disease or fetal programming. And the evidence came from many things. For instance, this was a paper which was first published in 1989 by Professor Barker, and he studied more than 5,000 men. And he noticed that there was an inverse relationship between the birth weight and the adult incidence of ischemic heart disease. In fact, this was more than 3 times more likely for these people to develop ischemic heart disease compared to those babies who were born with normal weights. So the children whom you discharge from NICU and a low birth weight will come to us many years down the later in our endocrine clinics with diabetes and metabolic syndrome and ischemic heart disease. So Professor Barker suggested that this is not just genetics, it is something beyond genetics, which is causing a modification of those genes. And he said that perhaps it's a nutritional factor which is activating these genes, which later on lead to ischemic heart disease and other metabolic diseases. And this concept we now call epigenetics. In utero exposure of malnutrition and other stresses switch on genes. We call it the thrifty gene hypothesis. These genes are switched on without there being a change in the DNA sequence, but through epigenetic modification, the methylation of the genes. And in the adult phenotype, that leaves a legacy of metabolic syndrome, obesity, and high risk of type 2 diabetes. The evidence came from a very interesting study, and this was published in 2000. It's a very landmark study. And it said that if you take children who were born siblings, so they studied 58 siblings born to mothers who were same mother before and after she became diabetic. And in these mothers, when the sibling who was born before they became diabetic, before she became diabetic, and the sibling who was born after the mother became diabetic, there was a 3-fold or nearly 4-fold higher risk of developing diabetes in those siblings who were conceived after the mother was diabetic. Why is this important? Because genetics was the same. You can hope that same parents, same genetic legacy which these people have. However, there was something in the intrauterine environment which left seeds for the diabetes to develop 4 decades later. So this is the evidence for the epigenetics. And for the neonatologists, and especially for the males, it's important to remember that it's not just the maternal environment. Even the sperms carry small RNA molecules. Now, you know RNA is not genes. RNA is produced from the gene. RNA is produced when genes become activated and expressed. So these small RNAs, which are packaged in the sperm, go and create signals and signatures in the offspring. So to say that a father's environment influences the baby is very important. So when we say, look after the mother, it is very important to look after the mother. I think we should also say, look after the father also, because healthy parents will lead to healthy children from both sides, right? The last part of this mechanistic understanding is the placenta. It is an endocrine organ, and it produces hormones such as HPL, human placental lactogen, and human placental growth hormone, both of which then lead to the insulin resistant stage. And the insulin resistant state which maintains the hyperglycemia which is necessary for fetal nutrition. But when it is disrupted, it can lead to antibodies coming across into the baby and epigenetic influences coming to the baby and causing disturbances there. The placenta is an endocrine gatekeeper. It makes sure that the nutrients reach the baby. Also, the important hormones which the baby is unable to produce itself reach the baby, such as thyroxine. But it makes sure that the larger molecules, such as the maternal insulin, which is a large peptide molecule, doesn't cross, which is why when in maternal hyperglycemia, there is fetal hyperglycemia, but there is not fetal hyperinsulinemia until and unless the fetus himself starts to produce more insulin in response. So coming to the second part of my presentation, exactly at halfway point, now I'm going to be talking about the mechanism was very important. The mechanism enables us to understand what we talk about. But now in the second part of my presentation, I will look into briefly, very briefly, how some maternal endocrinopathies have neonatal sequelae. Maternal endocrine disorders can influence a baby in many ways. First of all, some maternal hormones do cross the placenta and can affect the fetus. More commonly, maternal antibodies cross the placenta and create transient fetal endocrine pathology. In addition, indirectly, maternal metabolic disturbances as a consequence of maternal endocrine diseases, those altered metabolites reach the fetus. A most important example is glucose. And many of the medication we use to treat our endocrine mothers also reaches the fetus. We have covered the glucose and metabolic axis in the mechanistic aspect, so we'll quickly go through it. We covered the Peterson hypothesis of maternal hyperglycemia eventually leading to macrosomia and epigenetic memory in the neonate. When the cord is clamped and the maternal glucose is cut off, the fetal insulin overproduction persists, and that leads to slow clearance, and in that phase there is neonatal hypoglycemia. So infants of diabetic mothers, both of these babies are infants of diabetic mothers. The one on the right is macrosomic, the one on the left is has a growth retardation. It is estimated at about 2 to 16%. There's really very little clear data, especially from this part of the world. But approximately 2 to 16% of women develop, this prevalence among the pregnancies have diabetic pregnancies. And it is important to know that South Asian ethnicity, which is us, confers an increased risk. So we probably are at the higher end of this. We should differentiate. It's very important to differentiate diabetes occurring in a pregnancy during the pregnancy for the first time, what we call gestational diabetes, or a pregnancy occurring in a woman who was already diabetic. And this is very important to know. Why? Because a woman who was already diabetic was hyperglycemic at the period of conception, was hyperglycemic at the phase of organogenesis, and there's a longer trajectory of hyperglycemic exposure to the baby. Therefore, teratogenesis occurs in these people. These are where you see all the serious defects such as neurotubular defects, caudal regression syndrome, TGAs, etc. But in mothers with gestational diabetes, typically this kicks up in the second half of the pregnancy. By that time, organogenesis is completed. The fetus is fully formed, is growing. So this is where an excess of nutrients causes macrosomia. Vasculopathy, being a feature of chronic diabetes disease, is common in mother with existing diabetes and does not occur in women who just have short-term gestational diabetes. And similarly, the severity of many other conditions such as neonatal respiratory distress and polycythemia is worse in mothers with pre-existing diabetes. Management has been covered very extensively in the workshop yesterday also, including how early, the critical things, screen, feed early, and monitor. Coming to the thyroid axis. So the thyroid axis, the fetal thyroid does not develop until starts developing about the 12th week, and it completes its development around the 20th week. Until this time, the fetus needs thyroxine. Where does it get from? He gets it from the mother. So maternal thyroxine at this stage is critical for the development of the fetal brain. And if there is hypothyroidism at this phase in the mother, there will be neurodevelopmental delay and other sequelae of which are pretty commonly seen here because we do not follow this. About 20th week or so, the fetus becomes autonomous and reaches about independence in his endocrine glands. So we need to make sure that at the time of conception and before conception, in fact, we should make that the mother's thyroid levels are optimized, and we try to maintain the thyroid in slightly um, over higher level of thyroxine and lower level of TSH. Why? Because again, this thyroid hormone, this thyroxine, is what drives the fetal brain development. So basically, we optimize the TSH to slightly lower side. In the first trimester, especially, we keep it under 2.5. What about maternal thyrotoxicosis? So this is not my slightly altered presentation. So maternal thyrotoxicosis should be treated, but should be treated with a drug which has the least chance of causing fetal damage. And in the first trimester, this is propylthiouracil. It is a slightly hepatotoxic drug, but it has lower risk of embryopathy. But after about the second trimester starts, there is less risk of the fetus developing these problems such as embryopathy. Then we switch to methimazole because it's a more effective drug and has less hepatic toxicity. However, if the fetus is exposed inadvertently to methimazole in early pregnancy, then there are risks such as cutis aplasia. Another thing is that if we overtreat the mother, remember that fetal thyroid is not active at this stage. If we overtreat the mother, if we make the mother hypothyroid, if we increase the access of the drugs, the baby will become hypothyroid also and will develop neurodevelopmental delays. The placenta is a barrier. It does not let T3 cross because T3 is inactivated by placental dehydrogenase. It is the active form. Instead, T4, which should be considered as the prohormone, crosses, and then that is the one which is needed for neurogenesis, and it is activated at the level of the fetus itself. So how should you screen for neonatal hyperthyroidism? It might have been covered in one of the sessions already, but just for the sake of completion of this talk, if there is a mother with Graves' disease, then you should check for maternal TRAB. TRAB is TSH receptor antibody. This is the antibody which causes the autoimmune reaction in the thyroid and causes the thyroid to become thyrotoxic. And if you see here, TRAB crosses the placenta, and therefore it can cause A, fetal goiter, and B, it can cause fetal thyrotoxicosis. But this thyrotoxicosis will be transient once the baby is born, because over a period of next 3 to 6 months, these antibodies will be cleared from the system, and the baby will become euthyroid afterwards. So basically, if you see a mother of an obstetrician who is looking at a mother with thyroid disease, that obstetrician should monitor maternal thyroid, inform the neonatologist that this is a high risk infant. Please check these antibodies in the cord blood, repeat the thyroid function test, and also at a later stage, because the fetus may become, and one of the clues is fetal tachycardia. We have, I'm nearly towards the end of my presentation for those people who are waiting. The adrenal axis, very briefly. The maternal cortisol does not reach the fetus because it is inactivated by the placental 11-beta hydroxysteroid dehydrogenase. Unless this is overwhelmed, maternal cortisol will not do anything to the fetus. But in cases of Cushing syndrome with very high levels of maternal cortisol, this placental shield may be overwhelmed, leading to various consequences of the fetus's exposure to cortisol, including transient neonatal adrenal deficiency. And this may occur more commonly in the cases of synthetic glucocorticoids such as dexamethasone, because that crosses the placenta. It is not inactivated by 11 beta hydroxysteroid dehydrogenase, and therefore that can cause neonatal adrenal insufficiency. Apologies, this slide has become slightly scrambled in being transferred into the system, but you can see most of it. The important thing to remember is that iatrogenic adrenal insufficiency as opposed to CAH. Both of them present with adrenal insufficiency. Both of them present with shock. Both of them present with hypoglycemia. But only the CAH, salt wasting CAH, will produce electrolyte disturbances. In cases of iatrogenic insufficiency, such as that which is produced to the maternal dexamethasone reaching the baby, what will happen is that the mineralocorticoid axis will stay untouched, and therefore the baby will not become, electrolyte disturbances will not occur. One slide for the calcium axis. It is like a seesaw. Hyperparathyroidism in the mother, hypercalcemia in the mother will suppress the fetal parathyroid, and when the fetal parathyroid is present, once the mother's cord is cut out, then the parathyroid which is suppressed will lead to hypocalcemia, jitteriness, whatever seizures you see. And conversely, with maternal hypoparathyroidism, low calcium will trigger maternal, low calcium in the mother will cross to the baby and lead to the fetal parathyroid stimulation, and that can lead to osteopenia in the baby. Lastly, environmental disruptors. All of you have, they used to be water bottles of plastic. Now they have these glass bottles, because plastic is bad. Plastic contains substances which you call environmental endocrine disruptors. Bisphenol A is most commonly known. Even, in fact, many people now, many young mothers also know that BPA free, they need to get BPA free bottles. I would say, get a mother. A BPA free bottle will not do what the mother does. But BPA is an important suppressor of the reproductive system, and this BPA in the fetus can lead to a lot of neurodevelopmental and growth and metabolic disturbances. Lastly, I promised to talk about Ozempic babies, and that is perhaps what many people want to know about. So Ozempic, if anybody knows, is a drug which is now very commonly used for, it is an anti-diabetes drug. It is misused to lose weight by many people who are clinicians and many people who are not clinicians. So what is happening is, Ozempic is a GLP-1 receptor agonist. It is a drug which is a very good drug, one of our favorite drugs. We love it, but we love it for diabetes. Unfortunately, it is abused to cause weight loss. And it is being given by aesthetics people, by beauty parlors. God knows who else is giving that. So we know that this is a very long-acting drug. It needs a minimum of 2 months washout before somebody should attempt to conceive. But what happens is that many of these women, it's not indicated in pregnancy. No way, it is not indicated. But many of these women who are taking Ozempic do become pregnant. And then what happens? These fetuses, which are never meant to be exposed to these drugs, are exposed. And among the adverse outcomes, you can see neonatal hypoglycemia, also large for gestational age, RDS. So this is where we need to educate our people. And again, currently in animal studies it is safe, but pregnant studies, there aren't any, because there should not be any. So finally, what should the neonatologist look? If the mother has these conditions, such as Graves' disease, Remember to check the cord blood for both the thyroid hormones as well as TSH receptor antibody, and watch for tachycardia, which is a sign. If the mother has gestational diabetes or diabetes, monitor the glucose and watch for later consequences such as respiratory distress syndrome. If the mother has hyperparathyroidism, monitor the calcium levels, and these may occur, seizures may occur. And finally, a mother with polycystic ovaries, which I left out for now, again, these have a high risk of respiratory distress syndrome. And with that, I'm at the end of my presentation, almost exactly on time. And this is what I want to say, that you can't treat patients in silos. The neonate who is seen in a nursery, the fetus who is developing inside the uterus, and the mother, that is one whole, one continuum. So it makes sense. The management of the pregnancy, and in fact before pregnancy, at the level of conception and all, should be done as one unit. Because if the maternal fetal unit is one unit, so should be the unit of the endocrinologist, the obstetrician, the neonatologist. And that's my take-home message. Thank you so much.
Thank you so much, Professor Khadija Irfan. I would like to thank all the four speakers for their very knowledgeable and informative talks. And now, if there are any questions from the audience for the learned speakers, please go ahead.
My question would be from a second speaker regarding the neonatal diabetes mellitus, that before the use of insulin infusion pump and before the genetics or shifting over to sulfonylureas, if you have to use insulin, which insulin should be used and what should be the schedule? Long-acting, biphasic, which insulin should he recommend?
Thank you very much for your question. So, long-acting insulin analog like glargine that we can use safely, that's one of the options. If you don't have that, you could even try NPH twice daily. That's an alternative as well. Detamir or levemir, that's another option as a starting insulin.
Assalamu alaikum ji.
You mentioned that obviously genetics is most important as regard the neonatal diabetes mellitus is concerned. There are mutations which would not be responsive, which would require insulin. So in mutations which are not KATP, which you mentioned, which would be responsive to sulfonylureas, genetics is not available everywhere, and sometimes we do face problems, especially in a resource constrained situation. So can we empirically use sulfonylureas as a treatment for overall neonatal diabetes mellitus, just to see whether these patients respond or not?
It's worth trying, yes. If it's available, it's worth trying, but you need to become a bit patient to test the outcomes of that. So don't give up on that quickly to say, well, the patient did not respond. But meanwhile, you need to monitor closely in case of hypoglycemia if you haven't reduced the dose of insulin. So you need to watch closely and carefully for that. Yes, it's worth trying it.
And can these patients who respond to sulfonylureas or the KATB mutations, they can develop diabetic ketoacidosis?
Not necessarily. Their risk much less than the others, but it could happen as well. However, as I said, the incidence of that is much lower.
So I have a question for Dr. Hussain. Hussain, like we are sending genetics for the last 1.5 years, and apparently the results are very interesting. Like you actually showed that somehow Walcott Rollison is very common. Like we got 8 and 9 cases of Walcott Rollison. Along with that, somehow the kids were presenting within 3 to 4 months age of neonatal diabetes, and genetics turns out to be negative. And then we asked the exeter that what would she do? They should treat as a type 1 diabetes. So what is your experience in getting the negative genetics in a neonatal life? And in Pakistan, we just have anti-GAD65 antibody. They were also negative. Do you think it's a type of type 1 diabetes, or maybe some new genes who need to be get invented?
Well, recently we start learning as well about the autoimmunity that's happening at early age. For example, patients with trisomy 21, when they develop diabetes, they could develop it in the first or second month of age. And then you could have an element of positive antibodies. Therefore, you treat them, start with the, as I said, the umbrella neonatal diabetes. That's the label that we give. But when you get the antibodies that results positive, you switch the diagnosis from neonatal diabetes to type 1 diabetes. Okay. So coming back to your question, we are learning and we are witnessing there is autoimmunity that's still happening at quite early age. So if you have positive antibodies, that could be type 1 diabetes. And as we are, we've just seen that the antibodies, the genes are still yet being discovered. And in just 2 weeks ago, we shared in the Feed Endo Cafe that new genes have been discovered that is associated with neonatal diabetes. And the list is growing. The good thing about the NGS, the next generation sequencing, the panel is expanding as well to catch up as much as we can for gene mutations related to neonatal diabetes. So perhaps we still see more genes coming up. So negative genes doesn't mean that there is no, but this is what we know so far. Perhaps something is going to be discovered.
Yeah. And one more, I know it's a very basic question. What is the significance of HbA1c? Like sometime, we received a call at 28 years old newborn having persistent hyperglycemia. We do know that they have a lot of fetal hemoglobin. So when we should rely on HbA1c, and because we are seeing a high HbA1c at the age of 28 days of life, so how you interpret it?
That's a very interesting question. We know that the HbA1c is reflecting for the life of red cells 3 months time. Say, for example, at time of diagnosis, the child is only 1 month old and got the HbA1c, say, for example, 10%. How are we dealing with that compared to another baby with neonatal diabetes at 1 month of age and the HbA1c, say, for example, is 5%? How are we interpreting these two? So first, if the HbA1c is high, that could be truly reflecting the frequency of hyperglycemia that's been happening and this child has been exposed to, even for shorter time periods. So for the last 2 weeks, he's been hyperglycemic, but that was enough to increase the glycated HbA1c. So we think that's significant. Meanwhile, if the HbA1c is 5%, that doesn't mean this patient hasn't got neonatal diabetes because HbA1c wasn't elevated, but you just deal with the hyperglycemia that you are having. The importance of that comes afterwards. So after diagnosis, 3 months afterwards, you see with the trend of HbA1c, is it going up, is it flat, or is it coming down? So preferably we see the HbA1c coming down compared to the HbA1c at diagnosis.
Thank you.
My question is from Professor Junaid Habib. This is regarding supplementation of calcium and phosphate in the preterm babies.
Yeah.
Under what gestational age would you recommend that, barring extremely preterm babies, and you would recommend that this supplementation should be done? Because the problem is that we do not have breast milk fortifying. And so that option is generally gone. So we have to supplement with calcium and phosphate. And the practical problem is that calcium and phosphate preparations are not very, especially phosphate preparation, are not easily available here. The options are very limited. So can we do just by giving the vitamin D normal requirement, is supplementation essential?
So the question is that if we don't have these supplements, how to, on discharge, how to supplement the baby. That's why I showed you that chart, that continue with the breast milk and add these 3-4 feeding depending on your levels of alkaline phosphatase, phosphorus and calcium, and then do it accordingly with the help of this formula. This is one way. But let's say if you have a symptomatic baby who get the fracture, who get the metaphyseal, okay, and if you don't have those supplements, then IV sodium, I think phosphate is available, this thing.
Yes, we only have calcium P syrup available, what you are saying, and calcium P contains only 20%
syrup
of phosphate,
yes,
as calcium phosphate. It contains only 210 milligrams of calcium phosphate. For the phosphate to go up, we need to increase this dose of syrup calcium P, and would that not cause a higher level of calcium in it? That's the problem.
But the other thing as I told you, the calcium is very tightly controlled. So don't worry that the calcium will go up, because calcium control, because then the parathyroid hormone goes down and the absorption goes down. So you have to focus on the phosphate, either through the formula or this calcium syrup, whatever you have. But if you have the problem with the symptomatic baby, with the fracture or with the fraying or cupping, then it is better to get this IV sodium preparation, which is available in Pakistan.
In phosphate is the most sensitive indicator.
Phosphorus is the main for metabolic bone disease. Okay.
Assalamu alaikum. My name is Dr. Tahir Shaheen, and my question is from Dr. Hussain regarding the transition from insulin to sulfonylureas. You mentioned only about the regarding the prerequisites for transition. You talk about genetic diagnosis, then you shift. Can we use C-peptide level as a marker to know whether we can rely on C-peptide only to decide whether we can give a trial of sulfonylurea, and can we use C-peptide level as a marker after starting the sulfonylurea, whether the increased insulin is coming out of the calcium channels?
Very clever question. I haven't looked into that personally, and I'm not aware of research published into that. Perhaps there are some. Theoretically, yes. So if you give the sulfonylurea and then you start having more production of insulin, so yeah, you would expect the C-peptide to go up. Especially at time of diagnosis with neonatal diabetes, we are expecting the C-peptide to be low. So perhaps yes, it can be tested, but I haven't got any kind of real data or real experience on that.
And how C-peptide behaves differently in neonatal diabetes and type 1? I mean, in the diagnosis of, can you differentiate type 1 and neonatal on the basis of somehow C-peptide level?
No, I doubt this, because in both conditions, the beta cells are dysfunctioned, therefore are not producing insulin. The difference here that they use to discriminate between type 1 diabetes and neonatal diabetes is the presence of antibodies.
I have one more question. What is the best time to advise the parents regarding insulin pump, whether it should be immediately after the diagnosis and initial management, or the parents should be they should be expert on basal bolus and on insulin dilution, then afterwards they should be advised about the pump?
That's another amazing question, because it's a very practical question. So first of all, we need to share like a common ground with the parents. Let them know how to inject the insulin, because the pump can fail at any time. We cannot trust the pump 100% that's going to work. So if the pump fails and they don't know the basics how to inject insulin, we are going to create a disaster here. So we need to make sure they know how to inject insulin. Let them have the experience of giving the subcutaneous insulin for some time. Let's say, for example, a week or so. And then once they are established, they know the basics, and then you can move on to the insulin pump if it's available. It's easy to start the insulin pump in the neonatal period because there's no much carb counting, it's only milk. And then if you just show them how to carb count, and then you build up on their experience as the child is growing, the outcome is really good. But it's difficult for them. For example, they haven't started during neonatal period, and then during the infancy, when the baby starts weaned and then being on multiple or different type of foods, and they say, here you go, now you need to know proper carb counting before you switch to insulin.
What is your experience regarding transition from the insulin to sulfonylureas in mutations which affect the KATP channel, and especially in that mutations where sulfonylurea should work? What is your experience? It's 100% transition, or they remain on, even in that mutations where KCNG and ABCC8 is?
Worldwide, it has shown 90% response. So you still have 10% who are not responding.
Thank you very much.
My question is to Dr. Junaid. Till what age the surveillance for this bone health should be done in a preterm neonate, particularly in regard to those who are premature?
Okay, so
till what age, like, you would find it safe, like, okay, we don't need it actually?
what we are doing that after the discharge, we follow those babies at least for 6 months, and every other month we are doing which we call bone profile, calcium, phosphorus, alkaline phosphatase. If it is up to the mark, if this thing, then we stop at, because of the time I have to go. As soon as the 2 readings of alkaline phosphatase less than 500, we stop the screening.
And then you continue with the same dosages, or when would you stop the supplementation actually?
Supplementation only we start when the trend of alkaline phosphatase is increasing. Okay, it go above 700, then we check. If it is go above 800, then we add the vitamin D, increase the dose of vitamin D, and then supplement with phosphorus also. So that's the thing. I will give you the protocol because I have to go very fast on that. That it is very clearly written that if it is 600-700 alkaline phosphatase, start with vitamin D, increase the dose, and then add phosphorus.
So once you went to stop actually the supplementation and the...
That's I'm saying that at 6 months of age, the 2 ALP should be less than 500 or less, then you can stop the supplement.
For you to mention that you're doing the targeted screening, you're not doing the universal screening, you know.
So this is a good point by Rehan that we are not doing the screening in all the babies, okay? So those who are still, because we are catering very small baby like 22 week or 23. So automatically every 2 weeks we are doing the blood works. They are screening. But all other babies we are doing the targeted, we see the risk factor. The baby has the BPD, baby has required the steroid or the furosemide or something like that medication. Then we do the targeted this thing. Not all the babies should do this.
My question is from Dr. Khadija. This is regarding, because I'm not at all familiar with these, because we pediatricians are not used to these GLP-1 or just for the sake of my knowledge with Ozempic and the other one, tirzepatide, which generally the mothers would ask, which one is better as regard the weight reduction is concerned as in terms of side effects?
As far as Pakistan is concerned, we do not have any drug which is licensed for weight reduction in the category of these GLP-1 receptor agonists. Ozempic is licensed only for diabetes. And there is a bit of science to it also, because the dose of Ozempic, 1 milligram, is that which is very effective for reducing diabetes. But for achieving weight loss, you need to go to the higher dose salt, which is called Wegovy, which is a brand name, but 2.4 milligram. So GLP-1 receptor agonist has a mechanism that lower doses controls diabetes, higher doses weight loss is more effective. So we do not have weight loss drug in Pakistan. It is being abused to create weight loss. And of them, tirzepatide, because it is dual agonist, it acts both as a GLP and GIP agonist. Being dual agonist, it is more effective, whereas Ozempic or semaglutide can cause up to 16% body weight loss at the full doses, at the weight loss doses. Tirzepatide can cause up to 25, can produce up to 24 to 25% weight loss. And there are newer drugs which are coming on, which are triple agonists. So those are going to be really changing the whole situation once they come in. But for now, the take-home message for everybody is we do not have a weight loss drug in Pakistan.
What about the side effect profile? Side effect profile out of these two?
Yeah, you're worried about the eyes. You're worried about the eyes, the fact that it causes non-ischemic anterior optic neuropathy. And I would say that that is so very rare that it's not even in the box warnings. Less than 2 per 10,000, 0.02%. So the problems that can occur due to obesity and diabetes are like 90 per 1,000. So the risk of adverse effects is very minimum, we take care. For instance, we take care that we do not give these to people with a history of multiple endocrine neoplasias, familial tendency of thyroid cancer, familial tendency of any cancer syndrome. We do not give these drugs to people with a history of pancreatitis. Again, these are a good endocrinologist who does all this questioning. When it is being abused and is given by beauty parlors, then nobody is checking these things. Thank you. And a baseline eye scan is always good.
My question to Professor Khadija.
Really? Okay.
And coming from me,
and
first Khadija, it was a very, very nice presentation. And coming from me, it means something, you know. Secondly,
thank you so much.
To be honest, I don't know how to put this question, but about genetic basis of diseases. Currently, the neuroscientists and these geneticists, they don't believe in genetic basis of a disease, but epigenetics.
That is right? Precisely what I said, epigenetics,
yeah, you said so.
Switching off of genes.
How to prevent these problems? Simple
so
question,
epigenetic is exposure, environmental exposures. In a word, epigenetics means environmental exposure. So, for instance, why is it that longevity in Pakistan is 66 to 68 years and in the US is 88 years? So what is there? We are not so genetically different. Even Pakistanis who are living in the UK expect a longer life expectancy than those who are living here. Why so? It's because same genome, same genetics, different environment. How can you prevent the environment? That's the question that you all want to know. You can't. This is perhaps something.
You can choose that whatever what you call that's old, that male and female, then what kind of a male you have? You want to be a very high intellectual male, or you want to be a normal person? So these are the things coming up. I think in the future, what Professor Khadija is saying, which is true, that environmental factor is going to be there. It can change the thing, but in the near future, the genetic engineering will change a lot of things in our thing. Yeah, exactly.
So we'll have the last question
yes,
from Dr. Sikandar.
Yes, sir. It's last and emotional. I want to ask an emotional question from you and Professor Haq. From many years, I thought you have actually mentioned about the vitamin D supplementation for calcium metabolism. It is hard to believe that for breastfed babies, nature is not providing the adequate nutrients. Is it we are missing some nature's philosophy which is yet to be explored? My question is from Haksab and from you.
So my answer is simple. Nature is providing and telling us that these babies not supposed to born. These babies supposed to born at 40 weeks, okay? And the milk nature providing is for that baby, which is born 40 weeks. So the amount of, now we are, because of this scientific revolution, we are saving 22 weeker, okay? Now the milk is not enough. So it's not that nature don't want it. It's the thing that we, evolve too much, that we are fighting with the nature, okay? So 22 weeker, 23, 24, 32 weeker, the amount of the milk, the nutrients, the macro and micronutrients of that milk is not that enough. Now come to the full-term baby with vitamin D. All of us sitting here, I am not exaggerating, 89% of us is vitamin D deficient. So if the mother is vitamin D deficient, then whatever the calcium level of mother is, whatever the calcium level of the mother's milk is, it will not going to absorb. So you have to give vitamin D. Vitamin K, you have to give vitamin K, okay, to babies to stimulate the coagulation, cascade. Otherwise, the chances of bleeding is very high. So it's actually the nature telling us what to do, and they are more actually knowledgeable than us, as written in many years ago in Quran that you have to feed for 2 years of up to 2 years of age the mother's milk, and now it is proven that we have to. Sir, you want to add?
I think, Sikandar, the first answer is correct in the sense that we are trying to cheat nature. We are trying to cheat nature by keeping 22 weekers alive, 23 weekers alive. We were not supposed to be there. And therefore, we are facing many problems in keeping them alive. One of the problems is the osteopenia, which we see, lack of calcium and vitamin D. But when we come to the term, quite often, I'm not quite sure that I fully agree with Junaid here that all of us are vitamin D deficient. I think there's a very interesting saying, sheep in Glasgow. In Glasgow, there is hardly a sunshine. It's always covered with cloud and rain. But the sheep in Glasgow do not get rickets or do not get vitamin D deficient. The only reason why they don't get deficient is because their nose, the skin of the nose, is exposed to a little bit of sun. So you really need very little sunshine to get vitamin D. So that's part I would slightly digress from what Junaid has said. But vitamin D utilization and accretion of calcium and phosphorus is very deficient in many even near-term babies and term babies. And I think, if I remember correctly, there has been a lot of work from Australia showing that if you add phosphorus and calcium very early on in nutrition, even these very preterm babies do not get osteopenia of prematurity or metabolic bone disease. So I think what we are, to summarize, to answer your question, I think for the 22-23 weeker, we are trying to cheat nature and we are not winning very in that. But near term, we need a little bit of supplementation. You see, the other thing which we haven't shown here, but as showing in Karachi, you follow a growth trajectory, don't you? I mean, you have a growth chart. Which growth chart do you follow? And I showed them 3 growth charts, WHO, Fenton, and Hensworth. 3 growth charts. There's a difference of 300 grams for each gestation. So when for one growth chart you have a growth restricted baby, and the other one you have an appropriate gestation. Now, when you have a baby who is on the borderline, then those babies do require a little bit of supplement and fortification, and also the quantity of breast milk. The simple answer, for example, yesterday I showed you, I think yesterday, yes, that you need at least 30 minutes of breastfeeding to get adequate breast milk. So if you say you are breastfeeding, but you don't do it for 30 minutes, you're not getting adequate nutrition. So those are many reasons why you need to fortify some of these babies. Nature has done its job wonderfully. It's we who don't fully understand, or we are trying to cheat nature.
And at extreme of age, Sikandar, also we need supplementation. Okay, so I'm still okay, but after 2 years, I don't know what supplementation I am on. So this is we have to understand. But thank you very much, the chairperson saying that this is the last question. Thanks a lot.
Thank you very much, our chairpersons and worthy speakers. Now I invite Professor Farah Haroon for the next session. Meet the experts. She is Professor of Neonatology and Head of Department at University of Child Health Sciences and Children's Hospital, Lahore.
Assalamu alaikum. Well, after excellent 4 lectures, a lot of questions had been generated, and we got a lot of input from our experts. So, if from the audience, any more questions, all the junior residents, fellows, or even the senior faculty is requested to ask if they have any more questions from our experts. Any questions?
Assalamu alaikum. My question is regarding the management of neonatal rickets. If there are quite low value of the vitamin D, how much vitamin D can be given? Like in the pediatrics, STOS therapy is mentioned. Is it safe to go for that?
So as I showed that it goes by the, there is a table I showed that goes by the level of the vitamin D in that particular baby. Okay. So if you are at that deficient, you give 600 international. If you are that much deficient, you give 800 international unit, and it is safe. It will not cause hypercalciuria or the calcium stones up to certain limit. We used in a very premature baby up to 1000 international unit, and very nicely the alkaline phosphatase come down, and a baby didn't develop any fractures or any metaphyseal changes. So it depends on the level of. Now I know in Pakistan the availability of doing the levels and these things are difficult, but this is the only way. The other way you can do it, the tubular reabsorption. Just check the serum and the urine tubular reabsorption, and I showed you the table, and go accordingly. You will not overdoing, you will not underdoing. This is very perfect way to treat all this disease.
Thank you, sir. So my second question is regarding the values of the calcium. If we say the patient has early onset of hypocalcemia, what do you recommend? Should we go for the IV or the oral, and how much IV should be given?
Okay, so this is the question you asked yesterday also, that a full-term baby born and due to some reason, let's say sepsis or something, admitted to your ward, and you check the calcium level, okay? I told you that time I have to check the ionized calcium. If it is really low and the baby is symptomatic, then I only treat. Otherwise, we will not treat the hypocalcemia, even the ionized calcium. Ionized calcium is the marker of acute insult of the baby, like metabolic, sepsis, or all these type of things. But if the calcium is just, low, but not, baby is fine, asymptomatic, we don't treat it. We start with the difference here and in other part of the world, we have TPN easily available. So TPN is contain everything. So if we think that the baby will not start feed, we start feed even in the sickest baby. If the mother's milk available, we start. We at least the trophic feeding, and we continue built up on that. But let's say baby requires for some reason TPN, so it covers that part very easily, that because it has a macronutrient, it has a micronutrient, so we don't have that problem. But I think, what I suggest in my last slide, please focus on the feeding. If you feed the baby and with the breast milk, it will be very, very, very beneficial. I'll tell you that UAE is an Islamic country, but I'm talking about in USA, in Rochester, our exclusive breastfeeding at the time of birth is about 97%. We are hardly using any formula, anything, unless and until the mother has some problem, sick or surgical case or something like that. So if we focus in our country, in our situation, where TPN is not that available, if we focus in our mother's milk and fortify the mother's milk, I think we will come out of all these situations.
Thank you, sir.
Assalamu alaikum. My question is for Dr. Hussain. Thank you, sir, for a very nice talk. My question is, we are seeing a lot of our cases with neonatal diabetes have turned out to be positive for Welker-Trellison syndrome. So what about the options we have to prevent the early liver failure, and your opinion about liver transplant, how early we can go for it?
So far, there's no cure for this syndrome, as you know, but the awareness of it, the association with the risk of hepatic dysfunction could help us that detect the issues when it happens earlier rather than leave it till fulminant hepatic failure exists. So by doing this, we'll reduce the opportunities of reducing the possibilities of severe liver damage by taking care of those babies at early stage. Yes, liver transplant is something that is happening, and it's increasing longevity of those affected patients, but still that is not the cure for treatment. I'm aware that a colleague from Birmingham Children's Hospital, UK, they are working on developing a new gene therapy for patients with this syndrome. But to be honest, I don't know where are they up to with that. I've just been approached to share my patients with them, but I don't know where are they up to with that. So I hope that one day there will be a treatment for this condition, but so far we don't have treatment. Importantly, that we need to maintain good glycemic control, because maintaining good glycemic control will reduce the risk on liver and pancreatic damage. Be aware of the association with the hepatic dysfunction and treat early if things that happens. And be aware of other associated issues like hypothyroidism, for example. So if whether it's primary or secondary hypothyroidism have been reported in this syndrome. If you got a patient with this syndrome, got hypothyroidism undetected or not because we are not aware of it, and the patient is running long-standing hypothyroidism, that itself, the reduced basal metabolic rate because of lack of thyroxine, could affect the liver in another way, and therefore the liver dysfunction will be increased because of cholestasis secondary to hypothyroidism. So preventing all of these things will give the liver chance to be healthier for a bit longer period, and then therefore the patient will live longer.
Okay, thank you, sir.
I have a question from the experts. What is the role of cortisol deficiency in neonatal shock, and when should adrenal insufficiency be suspected? For any, yes.
This yesterday we discussed that cortisol. To be honest with you, neonatal shock is a very complicated thing, and we has to go what is the physiology of that shock. Either is a septic shock, is a cardiogenic shock, or it is what kind of a shock. Mostly we are facing the septic shock, and septic shock we start with the ionodrops. We don't give cortisol or hydrocortisone to normalize the blood pressure. If it is not working, the second line is vasopressin. If it is not working, then we go to the glucocorticoids. So we start with cortisol. We are not practicing and we are not recommending. Professor Haq, Professor Salman, Rehan is sitting. You're at. So same thing. Rehan?
So I want to...
Same thing. Sir? Same thing.
So I want to ask that if the blood pressure is refractory to treatment, should we give, and the baby has septic shock, should we give a single dose, or we continue cortisol and step up the dose till we achieve the required blood pressure?
This is our protocol, but somebody can check it. We started hydrocortisone as Q8 hourly, and then we taper to Q12, and then once a day, unless until blood pressure is stabilized. So we started always Q8 hourly. So this is our protocol, but somebody...
So, madam, just a small comment actually, because it is even in the different guidelines and PALS instruction that if you have a fluid-resistant shock, you need to give steroids, thinking of that maybe that shock is actually causing secondary adrenal insufficiency, damage to the adrenal ischemia actually leading to that. So again, as the sir said, it's very vary from case to case and it's very individualized. And if your supports are not working, it's a fluid unresponsive shock, steroids can be given 1 to 2 mg per kg per day, and but for that condition. Other scenario is that is this kid is really having a cortisol deficiency, that is totally different.
Yes.
Yeah, that is totally different scenario, because in that indication you're giving a steroid as a management of a shock, a resistant shock. So don't mix it with a cortisol deficiency.
So I'm just going to share a life scenario in that, like, we got this 28-weeker who we suspected a necrotizing enterocolitis, and the baby start ballooning his tummy, and so much so that we were under an impression that we wouldn't be able to ventilate that baby because the tummy start bloating. And what we actually found out at that time, that baby on ultrasound was actually an adrenal hemorrhages, and that baby was in that crisis. So that it all depends on the presentation, that what sort of, so you need to look at the cause.
Yes. The wrong is the wrong, sir, yesterday told us, because none of the medicine, okay, is without effect. I just talk about diazoxide when somebody presenting, okay. So one single shot, sir, can you explain that how much the load it can cause on the brain, hyperglycemia, you don't know. So if you need it, give it. So for example, it happened everywhere. I reviewed the case from USA just now, and they resuscitate a baby and they give 13 doses of epinephrine. So they are saying the same thing, what's the harm? The epinephrine, if you listen the third lecture, epinephrine, yes, ROSC, maybe you can get it, but it is killer to the cardiomyocytes. The cardiomyocyte will be died. So the comorbidity and morbidity is very, very high. So single dose, Dalal.
Before sir wraps it up, he's the final authority on it. Nowhere, people do not know whether blood pressure in neonate is a marker of flow or not. There is a good school of thought which says it is not one of the marker of flow. And secondarily, a cuff blood pressure is absolutely useless. People have to do it intra-arterial. और मुझे नहीं पता हमारे यहाँ पे कितनों की intra-arterial facilities हैं कि नहीं है. Sir is going to finally wrap it up.
I don't want to, I'm not the final authority in anything, but I just want to ask the audience, my own feeling is babies don't go into shock suddenly. It's the clinician who recognizes it suddenly. Oh my God, the baby has gone into shock. The baby has been going into shock for some time. It's you who have not been able to diagnose that. That is number one. And number two, what is your criteria of saying shock? Just because the baby is doing that, is that shock? What is the criteria of being shocked? Then, as Junaid said, is it cardiovascular, cardiogenic shock, distributive shock, septic shock, and the treatment is different for each and every item. The question for neonates, particularly however shock you say, and the people talk in adults about warm shock and cold shock. And if you put this into perspective in a newborn, sadly for us, the baby keeps on moving from cold shock to warm shock to cold shock to warm shock, or the other way around. So it is very difficult unless you have many parameters to measure at any one time, like you say, intra-arterial blood pressure, cerebral perfusion, gut perfusion. It's only then you will be able to manage. The question, sir, the question of what's the harm? तो जाके उसको हलवा पूरी खिला दो, व्हाट्स द हार्म? एक निवाला हलवा पूरी भी खिला, that is not a scientific argument. What is the harm? There is, every drug has got a positive and a negative reaction. Just giving a single dose of hydrocortisone will do nothing, to you. Endocrinologists are sitting here and they will tell you, they will never suggest to you just give a single shot and walk away. That is never done. So please, I mean, the other thing was also, which I don't want to express, but giving thyroxine, just idea. Kya kare? That is not good practice. That is not good practice. Even thyroxine, I believe, बहुत सस्ती मिलती है. नहीं, जब मिलती है तो बहुत सस्ती होती है, इसलिए दे देते. But to reflect on the harm what you're doing with giving thyroxine.
And one more thing which sir is not telling, this is a very famous thing. Whatever is true in physiology, it has to be true clinically. And if it is not proven clinically right, then we are doing something wrong. You got my point? So physiology has to be different in different things. One dose of cortisol, I don't know is there any effect, but I know the glucose will shoot up. And in the premature babies, hyperglycemia is dangerous as hypoglycemia. So we have to be very, very careful in recommending any medicine for that. Yes, sir.
That's one point. The flip side of the coin is that, let's suppose Dr. Hussain is over here. He has given a lecture. Thank you very much. Neonatal diabetes mellitus, 30 gene identified. We know from a previous lecture, hypoinsulinemic hyperinsulinism, 40 gene identified. Commonest gene involved, the same two genes, KCN1, ACCBBA, is just an up and down regulation of the same gene for the two different pathology, So if we are giving sulfonylurea in neonatal diabetes, then why can't we give diazoxide or octreotide or minoxidil, which blocks the calcium potassium channel? So that's a fruit for thought or the window of opportunity. Why can't we use an opposite of glabenclamide, which is minoxidil or, octreotide or diazoxide? As Junaid said, that every drug has to be started under precautions, like diazoxide causes pulmonary hypertension, minoxidil, all those things. But we have to outweigh the benefit. And as Junaid said, they should be all evidence-based. We cannot give it like as much as
possible. And sir,
think about our system.
Yeah, exactly, sir. How many of them, even in USA and Canada, where the advanced system, when they start diuretics for BPD, did they ever mention that at 2 weeks we have to check the bone? I showed you this is 2024 study, and it is very, robust study, very well designed study. It's not like somebody published. So to us, as I said in the beginning, keep it simple as much as possible. Go by the physiology, go by the reason. What is the reason behind it? Why is the sodium is low? Why? So, for example, if in your unit, Irfan and my brother, that in the night they said, baby has apnea bradycardia. Somebody has to go and see, whoever the doctor is, that why apnea and bradycardia. It cannot be just do the CBC, diff, blood culture and start on antibiotics. Because apnea and bradycardia due to many, many other reasons, okay? So as I said, that caffeine is good, extended caffeine is now incoming, but we have to keep consideration that it is called resorptions of the bone. So we have to balance everything.
Thank you very much, everyone, and sorry for the short time we have. I would like to invite our chairpersons to present souvenirs to our worthy speakers. So please come forward. I would also like to invite Professor Junaid Mohib Khan to please come on the stage and receive souvenir. Dr. Hussain Al Safar, sir, please come on the stage. Madam Khadija Irfan, Professor Khadija Irfan, Madam, please come. Professor Jaida, Madam, please come on the stage for souvenir. Amara Kaleem. I would like to invite Professor Khalid Haq for souvenir distribution to our worthy chairpersons. Major General Zishan Ahmed, Professor Tahir Javed, Dr. Kaleem Akhtar Malli, Professor Saima Ali, Dr. Amara Kaleem, I would like to invite Dr. Amar to conclude the session. Thank you.